I'd like to introduce myself. My name is Larry Doak. I'm your Chair for Human Services. I'd like to introduce the rest of the committee here today. Joined today is MLA Herb Cox, the Honourable Todd Gowdy, MLA Nadine Wilson, and substituting for Danielle Chartier is MLA Mowat. This is the first time the committee has met since the Assembly adjourned on March 17, 2020 due to the COVID-19. Before we begin our business today, I would like to make a statement in regard to how the committee will operate in the chamber. We would ask witnesses to only sit in the allocated spaces at every other desk, so to ensure physical distancing requirements are adhered to. Witnesses may speak at the microphone podium if they are required to answer questions. If there are more officials present than there are seats, we would ask those additional officials to wait in the hallway until they are required to answer questions. I also remind witnesses to state their name for the record before they speak at the microphone. If ministers need to confer privately with their officials during proceedings, they may do so in the hallway or the vestibule at the front of the chamber. There has also been a modification to the committee's voting procedures. Because some committee members may not be able to attend a committee meeting due to COVID-19 or related restrictions, committee members now have the option to vote by proxy during a recorded division if they cannot physically attend a meeting. A proxy form must be registered with the Speaker's office 30 minutes prior to the Assembly's daily proceedings. Lastly, I want to advise the committee that we will need to take periodic recesses to allow time for the Legislative Assembly services to sanitize their workstations when personnel changes occur. So please bear with us. If you have any questions about logistics or have any documents to table, the committee requests that you contact the clerk at committees@legassembly.sk.ca. Pursuant to Rule 148.1, the following estimates and supplementary estimates were deemed referred to the Standing Committee on Human Services today, June 15, 2020. The 2020-21 estimates: vote 37, 169, Advanced Education; vote 5, Education; vote 32, Health; vote 20, Labor Relations and Workplace Safety; vote 36, Social Services. And the 2019-20 supplementary estimates: vote 37, Advanced Education; vote 5, Education; vote 32, Education; vote 36, Social Services. Pardon me. Oh, 32, Health, sorry. Today we will be considering the estimates and the supplementary estimates for the Ministry of Health. We now begin our consideration of vote 32, Health, Central Management and Services, subvote HEO1. Minister Ryder is here with his officials. Minister, please introduce your officials and make your opening comments.
Thank you, Mr. Chair. Senior leaders from the Ministry of Health joining us today are Max Hendricks, the Deputy Minister of Health, Denise Mazza, Associate Deputy Minister, Mark Wyatt, Assistant Deputy Minister, Billy Joe Morissette, Assistant Deputy Minister, and Rebecca Carter, Assistant Deputy Minister, and Tracy Smith, Assistant Deputy Minister. Also joining us today is Scott Livingstone, who's the Chief Executive Officer of the Saskatchewan Health Authority. I'd also like to acknowledge that there are a number of other senior officials here today, and I'd ask them to introduce themselves as they are called upon to address the committee. The COVID-19 pandemic has resulted in an unprecedented fiscal year and a disruption to our health system never before experienced. Countless health officials were involved in extensive planning and preparedness. While we were looking forward to announcing a number of progressive budget initiatives in March, these announcements were put on hold to focus and respond to the serious threat of COVID-19 in our province. Thanks to the efforts of public health officials and Saskatchewan Health Authority officials who led the charge on the pandemic response, we are on track to resume the new normal. We're determined to move forward with our record health budget and the initiatives captured within this budget that will make a difference in improving the physical and mental health of Saskatchewan people. Our government has made financial support available to ensure our health system can continue addressing challenges presented by the COVID-19 pandemic. The COVID-related spending to date has been managed within the existing health budget that was announced on March the 18th. The federal government has announced they may provide funding of $14 billion to provinces and territories. Saskatchewan's portion remains unknown at this time. The health sector has redirected and supported resources to ensure a proactive response to COVID-19. Our government committed to supporting the Saskatchewan Health Authority in purchasing ventilators, hospital equipment, testing materials, personal protective equipment, and operating costs. At this time, Health has committed $118 million associated with the COVID-19 response. We are taking every precaution, such as expanding our COVID-19 testing protocols to closely track this virus and continue flattening the curve so it does not overwhelm our health system. The Ministry of Health and its health system partners are working closely together to ensure a coordinated response to the pandemic. There is a government-wide health and safety contingency fund of $200 million that will be available if required. It is crucial that we have funding on hand to keep patients, frontline staff, and all Saskatchewan residents as safe as possible. For this reason, we are committed to ensuring our health system is well equipped to handle any increase in COVID-19 cases and to report on any costs associated with the pandemic response. This year's provincial budget invests a record $5.8 billion in healthcare programs and services. This is an increase of $255 million, or 4.6%. It includes significant investments to support mental health and addictions, reductions in surgical wait times, women and children's health, and infrastructure needs in communities across Saskatchewan. I'm pleased to announce that operating funding to the Saskatchewan Health Authority will increase to $3.7 billion, an increase of $140 million, or 3.9% from last year. This is the highest ever budget for the SHA. $1.6 million of this funding will go towards additional resources and operating costs at the Saskatchewan Hospital in North Battleford, and $1.2 million towards organ donation system improvements, including the development of the organ and tissue donor registry. There are a number of other initiatives included in the SHA's funding, which I will speak about shortly. The Government of Saskatchewan remains committed to supporting the Saskatchewan Cancer Agency. This year, the SCA will also receive its highest ever grant, a total of $196.4 million in funding. This 10.3% increase will go towards enhanced cancer care services and oncology treatment programs. As I said earlier, the Ministry of Health's 2021 budget supports a number of key initiatives: infrastructure, surgical waits, women and children's health, and mental health and addictions. We have made major budget commitments in all of these areas, as well as seniors' care. We will speak to mental health and addictions investments at a subsequent session of Human Services Committee, but there is one initiative I'd like to highlight today. Estevan will soon be home to a new specialized inpatient treatment center for Saskatchewan people experiencing addiction to crystal meth. We have committed $1.4 million to establish this new center that will treat people from across the province and support them through their recovery. The center will use innovative protocols and medication use to support treatment, wraparound services in Estevan, and post-inpatient supports throughout the province. The center will have 15 beds for people recovering from crystal meth and another 5 beds for people recovering from addiction to other substances. Additionally, $150,000 is being invested to establish 4 pre-treatment beds and 6 post-treatment beds in Estevan. I look forward to sharing more about this innovative treatment model at a future committee meeting. The Government of Saskatchewan remains committed to reducing the time patients have to wait for surgeries in our province. This year, we have committed an additional $20 million to address surgical wait times, which adds to the $9.8 million investment we made last year. This funding will increase the number of inpatient and day surgeries performed and will allow for thousands of patients to have their procedures scheduled sooner. I recognize the impact of COVID-19 on surgical wait times as the system discontinued elective surgeries to ensure capacity and minimize risk to our patients. As we continue to resume surgical services, we will look for opportunities to appropriately invest this funding to address the backlog created through the COVID-19 response. This funding also assists with the costs of both pre- and post-surgical care services. This year's budget dedicates funding to a number of areas that focus on the health of women and children. As part of our multi-year funding commitment, $15.9 million has been allocated to hire more physicians and staff at the Jim Pattison Children's Hospital. This will ensure that children receiving treatment at JPCH receive the best possible care and that families feel supported by a full complement of doctors and staff caring for their children. Another investment in Saskatchewan children includes the $827,000 we've committed to improve our province's pediatric hematology program. Women who have low-risk pregnancies will benefit from the $410,000 investment to expand our province's midwifery program. This will allow for the hiring of 3 additional midwife positions. We have also committed funding to a number of cancer programs dedicated specifically to women's health. Nearly $1.8 million in funding will enhance Saskatchewan's gynecologic oncology programs. This funding will also allow our province to recruit a 6th specialist, as well as other healthcare providers. $1 million has been committed to Ovarian Cancer Canada to fund treatment, research, and clinical trials that will improve outcomes for ovarian cancer patients in Saskatchewan. These funds will stay in Saskatchewan and will support OCC, the Saskatchewan Cancer Agency, the University of Saskatchewan, and provincial gynecologic oncologists. $611,000 will go towards modernizing cervical cancer screening through a technology called liquid-based cytology. We've also committed a $616,000 boost in funding to our province's sexual assault nurse examiner services. The Government of Saskatchewan remains committed to supporting families who have children experience autism spectrum disorder, and we will continue our record of increasing ASD individualized funding. Families will now receive $8,000 annually through this program, a $2,000 increase. About 535 Saskatchewan families will benefit from this increase that gives parents more flexibility in choosing the services they access to best suit their child's individual needs. This year's health budget also invests in key infrastructure for our hospitals and healthcare facilities and in a number of capital projects. Recently, our government announced a 2-year, $7.5 billion capital plan to stimulate our economy and support economic recovery. In the health sector, $203 million of this funding will support new infrastructure and priority renewal projects over the next few years. In 2021, $43.7 million will go towards maintenance and capital projects. $25 million will be used for facility upgrades and maintenance to keep patients, families, and staff safe and to allow for the continued delivery of healthcare services, and $18.7 million will be used for future capital projects. Plans are currently underway on where to best direct these dollars, and I look forward to these future announcements to benefit Saskatchewan people across the province. Last year, we announced plans for a new long-term care facility in Meadow Lake. We have committed $15.7 million to support this project's completion. Additionally, $15 million in capital funding will go towards the planning, design, and procurement of the Prince Albert Victoria Hospital project. $2.5 million in existing funding will go towards site selection, land acquisition, and planning for the Weyburn General Hospital replacement project. Royal University Hospital will see a major increase in capacity, as $7.9 million will go towards funding 36 new permanent acute care beds. Our support for enhanced services at RUH continues. We've also provided $1 million to support the operation of a new 4-bed epilepsy telemetry unit. In Prince Albert, we have dedicated $833,000 towards the operation of a new 10-bed palliative care hospice. Our government is committed to ensuring health facilities have the equipment and infrastructure they need to continue delivering high-quality health services to Saskatchewan patients. We've dedicated a total of $28.5 million for capital equipment, including diagnostic, medical, surgical, and IT equipment for health facilities across the province. Regina General and Pasqua Hospitals will receive a combined $13.9 million for electrical renewal. And additionally, eHealth will receive $13.6 million to upgrade infrastructure and ensure clinical systems and applications continue functioning appropriately. $2 million will also go towards a new CT scanner in Melfort, and $5 million will replace a linear accelerator at the Ellen Blair Cancer Centre in Regina. We'll also upgrade existing dispatch technology for emergency medical services by investing $1.4 million towards computer-aided dispatch renewal. And Northeast Saskatchewan will now better be served by a second ambulance in Pelican Narrows. We have committed $188,000 to this important and life-saving service. I'd like to thank the Chair and the committee for giving me the opportunity to outline some of the significant elements of this year's budget. I will speak to our major budget commitments for mental health and addiction supports and seniors at a future session of the Human Services Committee, and now our officials and I would be pleased to take questions. Thank you, Mr. Chair.
Thank you, Minister. Just before we carry on, I would like to say that MLA Fayaz has joined us also. So we'll open it now for questions. Ms. Moen.
Thank you, Mr. Chair, and I would like to thank the Minister and all the officials for being here today and getting set up in what is a rather atypical fashion for us to ensure that we have some ability to physically distance during this session. We got started a little late, so I'll get straight into some questions here. Some basic funding-based questions coming out of estimates to start us off. There are $148 million in COVID spending in health that was found within existing funds. So I'm wondering if you can speak to where this money came from. Were there any programs that have been canceled due to COVID or unexpected savings, I guess?
In a number of different areas, it would be, for example, some of the new initiatives that were announced they're still going to proceed, but they would have proceeded more slowly. For example, the surgical initiative we announced last fall. Also, as you're aware, elective surgeries, for example, and procedures were, we weren't able to do, so they were postponed. In the supply front, there'd be a number of supplies that weren't done. So it would be fairly wide-ranging. It would be across many different.
In terms of the reallocation of resources to the Northwest during the outbreak, can you speak to what the cost of that response was?
I'll start and I'll get our officials to have a discussion, and then I'll come back. I was just going to say, to start with, there would be some costs, obviously, to healthcare, because we had officials up there, we put resources up there, but it wasn't limited just to the health. It was the provincial security agency as well, government relations. So it would be more than just the Ministry of Health, but I'll see if I can get you a little more detailed example right now.
Provide a little bit more background on why I'm asking. I'm just thinking in terms of the $200 million that's allocated that you mentioned in your opening remarks through the Public Safety Agency for a contingency, and how far that money is going to go, basically.
So to your question, we've got a number of different categories here. Testing sites, in March, $14,000 was spent. April was $48,000. This is spending in the north. And May was just under $40,000 for a total of $102,000. Equipment renovation expenses was $82,000. Payroll was just over $1 million, $1,046,000. I'll come back to that one. And there's miscellaneous costs of about $28,000 for a total of $1.25 million. Some of that could be a bit misleading, though, because embedded in those payroll costs, though, would also be people who those salary costs would have been paid regardless. It was, in some of those cases, it was a matter of just repositioning them from existing positions to where they were in the north. But I think that gives you sort of a rough idea of sort of the dollar amounts involved.
Thank you. In terms of the $200 million contingency fund, can you speak to how that dollar figure was determined?
Would be better put to the finance minister and treasury board. That's where they would have looked, I think, across all the ministries and costs incurred to date and anticipated costs in the future.
In terms of COVID-related spending in health, what is the forecast that the SHA has for this upcoming fiscal year?
So thanks. The high-level estimates are probably in that $200 million range or slightly exceeding it. But the difficulty in coming up with that number is there's a number of factors that are difficult to put a dollar amount on. That amount doesn't account for any revenue that would be flowing from the feds, the federal government that had announced that they would be assisting with funding. We still don't have a dollar amount on that. And a significant part of that, of course, this won't surprise you, is salaries. But again, oftentimes those salaries are already budgeted for in another area and are redeployed. So for example, I'll use an example coming from the last question. Employees in the public health department were redeployed to La Loche to assist with tracing. So in that instance, that would show as an expenditure under COVID-related expenditures, but yet those dollar amounts, those salaries were already budgeted for in another area. So in the global picture, it wouldn't need extra funding. There's also, and again, as I mentioned in the previous answer, there'll be, I think it was the previous one or the one before that, there's some money saved on supplies because some procedures just haven't been done. And that's kind of wide-ranging. Obviously, we need to catch up in those procedures over the coming months and years, but you know, when they've canceled diagnostics, canceled surgeries, those sorts of things, you know, very unfortunate. We want to catch them up, but there's been some savings there as well. So those things would offset that total estimate, but it's very difficult to put a significant like a very specific dollar amount on right now, because frankly we don't know what the next number of months are going to bring as far as the second wave, or how many people would be testing positive.
In terms of what the ministry is preparing itself for, is there a particular model or scenario that is being utilized? I know the SHA has presented some modeling. Is there a particular model that's being utilized to plan for what the funding allocation looks like for this year?
Hendricks, Deputy Minister of Health. So for the purposes of developing our utilization and spending estimates for the fall, we continue to base it on the last modeling update that was provided by the SHA in conjunction with the U of S, which is kind of the mid-range scenario. That would see the province have 254,000 infections, approximately an average daily census in our hospitals of 1,736, an ICU census of 412, and 403 patients requiring ventilation. So that is based on a reproductive rate of about 3.12. Right now, our current reproductive rate is 0.67. We continue, this is dynamic modeling, so we continue to look at the experience in different jurisdictions and try to develop our modeling to fit the Saskatchewan situation. And so likely this will be updated again a couple of times, probably before the fall, as will our spending estimates as we go forward. So there are a number, as the minister said, there are just so many variables in trying to predict when and if the second surge will arrive and how severely it will impact our population. And so right now it is a bit of crystal balling.
In terms of the COVID testing sites, can you speak to how much we've spent on the setup of those sites so far, what we anticipate we will be spending throughout the year, and I guess, is there a plan built in within that those sites will be expanded, or has that process been completed at this point?
So right now, we have 54 assessment sites across the province. And unfortunately, we haven't got an exact estimate in terms of the manpower costs associated with that. We've spent to date or have committed about $11 million on testing supplies, consumables, that sort of thing, but that's what's been committed. That's not necessarily what has been spent, so that's reagents, swabs, that sort of thing. As we go forward into the later part of the summer and the fall, there will continue to be the PCR testing, which tests whether you have COVID-19, but there will also be the addition of serology testing. And so you'll know that the federal government have sent out, they're going to be doing a serology survey across Canada to kind of look at the prevalence of the number of people that have the COVID-19 antibodies. But going into the fall, Saskatchewan is planning on upping our participation in serology testing as well. It's an important component to an overall testing strategy. So I guess the bottom line is we need to do both to both understand how widely spread and how many people have the antibodies, but also as we reopen Saskatchewan, to understand where we do have any small outbreaks, that sort of thing, be able to detect them and contain them very quickly.
Thank you. Switching gears a little bit here, there is once again substantially more money being spent on the drug plan and extended benefits. Can you speak to what is driving this increase? Is it drug costs, utilization, et cetera?
Ministry of Health. In this year's drug plan budget, we have a total lift for the drug plan and extended benefits branch. Oh,
Sorry.
we're sitting here. Okay. Mark Wyatt, Assistant Deputy Minister, Ministry of Health. So in the budget this year, we have a total increase in the drug plan and extended benefits branch of $24,337,000, of which $21 million of that is directly attributable to the prescription drug plan. And then $2,530,000 is an increase in the SAIL program, the Saskatchewan Aids to Independent Living, and then we have $625,000 for the supplementary health program. I think your question was specifically around the drug plan, which is the largest part of the overall increase, and there are a number of factors that are resulting in the overall drug plan budget lift of about $21 million. There we go. So the overall acquisition cost has increased by about 5.3%, so that's the cost of actually the drug product itself. We've seen increases in dispensing fees, and we have had an agreement with the Pharmacy Association of Saskatchewan that resulted in increasing dispensing fees as well as some of the program costs that pharmacies are funded for. So there's about $3 million that was attributed to the pharmacy proprietor agreement that exists between the ministry and community pharmacies. There's another component of drug plan costs. There's a dispensing fee that goes to pharmacies. There's also a markup that pharmacies generate as part of the cost that is passed on to the funder, and that represents another $1.1 million. One of the big drivers of drug plan costs over the last number of years has been expensive drugs for rare diseases, or just expensive drugs in general. We're seeing both some niche drugs that are targeting orphan diseases, but we're also seeing some high costs for drugs that are being dispensed on a broader basis to broader disease groups. And so those have had a significant increase over the past few years. We've seen 2019-20, the actual expenditure was about $14.4 million for some of those rare disease drugs, which is an increase of about $6.7 million. And we're seeing examples of drugs now that come in. It's not uncommon to see an individual drug for one patient for 1 year that comes in at $300,000, $500,000. Some are now up to $1 million. So when you add with some of these conditions, you add one patient over the course of of the fiscal year, it adds $1 million, or it adds $500,000 per patient. So as we've seen some of those additions. Having said that, one of the things that we have been able to do to be able to offset some of these drug increases is we have been able to negotiate through our participation in the Pan-Canadian Pharmaceutical Alliance. We negotiate drugs, both generic and brand drugs, nationally, and we have seen significant increases significant reductions in our overall drug expense as we've been able to negotiate more of the drugs that are being added to the formulary, and in some cases, generic drugs being a good example, where we've continued to push down some of the prices that we're paying. So the overall increase is a combination of some of those cost drivers that I've mentioned, but also offset by some of the net reductions that we see through those product listing agreements for individual products.
In terms of capital, maintenance capital expenditures in health are set at $223.9 million. We submitted written questions, and the responses showed that the cost of deferred maintenance on health facilities has grown by about 59% since 2013, and it's nearly 3.5 billion now. By my math, 223.9 million is about 6% of what's needed in deferred maintenance costs, and with two-thirds of the former health regions reporting that the average facility condition index is critical or worse, how can we explain the underfunding in health infrastructure?
the dollar amounts that you quoted, certainly it's a huge amount of money. Just a number of things, I guess, I would address through that. You know, I won't go through sort of all the capital dollars we spent in the past, but I would say that there'll be a significant improvement in a number of areas then with just some of the projects that have been announced already. When you build a new capital project and take an old one offline, obviously that's going to help that dollar amount. You're looking at projects coming from nothing you're not aware of. You look at PA-Vic Hospital being done, when you look at Weyburn Hospital, long-term care facility in Meadow Lake, those coming online, that's certainly going to help. And then there's a significant amount of maintenance dollars coming as well. There's $55 million this year in the base, plus 25 were added through stimulus. Next year already we're aware there'll be $75 million plus whatever the base is set at that time. So there'll be some significant investments that will help in that regard.
Can you speak to which facilities are a priority for renovations?
the ministry works with the SHA to prioritize projects. And for, I guess I would describe them as more larger scale capital projects. You'll hear some announcements about some of that coming in just the next few days, but for more specific types of projects, and I guess I would describe more as, I guess, smaller capital projects. I'm just going to get Max to touch on that as well.
So I took it from your question that you're questioning which facilities we prioritize, but it's more about what areas of repair that we prioritize. So when we go into, when we look at the VFA information, we look at doing those critical maintenance projects that are important to ensure the life and safety of the residents or patients. So things like fire alarm systems, fire protection, sprinkler systems, nurse call systems, standby generators, but it also spreads into areas of structural work and roof window replacement. And to give you a few examples, right now we're doing a fairly large project in terms of renewing the electrical, basically all of the electrical infrastructure at the provincial hospitals in Regina, so the Regina General and the Regina Pasqua hospitals. So it's been a multi-year systematic upgrading process, replacing, refreshing all of the electrical infrastructure. So it's $13.9 million. We're spending $5 million at Wascana Rehabilitation Center to upgrade the building envelope this year. Things like, you know, something that came up at Dubé Center in Saskatoon to update the duress system. We're spending $1 million on that. And so we spend it on a variety of areas. It's everything from new windows, new roofs, painting, that sort of thing, but it's based on what's highest need out there in the system in terms of maintaining the facility's integrity.
Right, so I guess my concern is the accelerated rate that this cost of deferred maintenance is growing, and the fact that the investment into that is not growing at the same rate. We maybe are going to disagree on this, and we can keep moving, but one of the big concerns that was flagged for me was when the provincial auditor last year in June looked at the former Saskatoon Health Region area and essentially said that there wasn't a solid prioritization plan for work that needed to be done. So what's the long-term plan in terms of deferred maintenance within SHA facilities? Is there a plan what does it look like?
Saskatchewan Health Authority. So with the formation of the Saskatchewan Health Authority in 2017, a lot of this work has now come together under a provincial umbrella. So you see the organization looking at how we prioritize investments across a multi-year capital plan to generate the most value for that investment. As Max had already touched on, we do focus on life and safety, but also, as you would be aware, there is a big chunk of that deferred maintenance relative to some of our key facilities across the province where we have focused investment on large infrastructure projects. And a good example would be the electrical upgrades in Regina and Saskatoon, which are needed to actually accommodate care across the organization. But through that multi-year planning and prioritization process, we're making sure that we're making those investments that are building back up that infrastructure you're seeing. But one of the other challenges, as you know, is the sheer number of facilities, not just the age of them, but the number of facilities, and looking at how we organize ourselves at a provincial scale better around, for example, integrated facilities. So in Leader, as an example, we've got a brand new facility in Leader that is an amalgamation of 4 former facilities. So we've actually reduced our footprint and made a value-based investment in a facility that is more of a one-stop shop as opposed to 4 different sites. And that hasn't become what I would say the new norm, but it is something that's considered when we're looking at capital across the organization.
Thank you. I think we'll disagree on the amount of investment right now being adequate for catching up. Like I think we'll disagree on that. But I thank you for explaining what the processes are right now. We have limited time, so I want to move forward into some other questions. In terms of the health capital priorities for the year, there's some information in estimates, but I'm wondering what you can say in terms of what the building, the new capital requests were that were submitted and how many were granted.
Clarify, you said new capital requests. I'm not sure what you mean. From the SHA to, that goes through the normal budget process though. So I'm sorry, I'm just not clear on what your question is.
In terms of identified need for new capital projects, where are we at in that process?
The ministry, working with the SHA, has a list of, I guess, facilities that we have, I guess, over the, we realize have certain unique service requirements. So, for example, the project in PA is largely being driven out of the fact that the service needs are growing in the north, and it's a high needs area. And so, similar with Larange, long-term care. So things like that drive a lot of capital decisions. And so that in combination also with the state of the infrastructure. And so we look at all of this information, and also I think we need, in terms of scoring this and looking at, our available funding, some projects are a little easier to do than others, just some are bigger, right? And so a number of factors fall into this kind of, or these decisions about what funding or what projects will be approved within the budget every year.
The Canada Health transfer is budgeted at 1.3 billion this year, which is good. It's an increase from the federal government. Is there any of those dollars that are earmarked for specific programs and services that you could speak to?
So, in the actual Canada Health transfer, none of the money is actually targeted to specific programs other than maintaining the principles of the Canada Health Act. But there was the 10-year bilateral agreement that provided funding for home care and mental health, which was a separate agreement to the Canada Health transfer. So we have our funding amounts to 21-22 for that, but from 22-23 to 26-27, those amounts are to be determined.
In terms of the minister mentioned that there is some additional federal dollars expected. I'm wondering if you can speak to what that is anticipated to look like.
Initial tranche of funding that I believe was announced in February, or in March, sorry, was $500 million to assist provinces in preparing. And our share of that would be about a little over $15 million. So that's pretty solid. We have a good idea what's coming from that. What's less clear is the Prime Minister announced $14 billion to assist provinces with safely reopening, and the allocation, whether that'll be per capita or whether there'll be other variables attached to that, we don't know yet. And so I assume we'll be finding out. In fact, there are some discussions going on this week about that.
Thank you. In terms of access to information, I know a number of folks submit access to information requests. These legislated timelines are almost always missed, or have been for the in the recent past. Sometimes it takes almost a year to receive responses. Can you speak to what the issues are with the ministry's access to information process that are causing these backlogs and delays?
So I think there are several issues when it comes to FOIs. One is that the total number that we are receiving every year continues to go up. And, you know, I think that it's fair to say that also the complexity of some of the FOIs is increasing as well, where several thousand pages of materials that have to be gathered from various sources. So, you know, complicating that is obviously, and I've met with the commissioner on a couple of occasions about this, are, you know, maintaining kind of an adequate number of staff to support that work. But also to have processes and that sort of thing to make sure that they do move through the ministry at an appropriate pace. So, you know, of the 127 that we did receive last year, 76 were completed within the 30 days. About 23 were completed in around between 31 and just over 60 days. Some are withdrawn and some have been carried forward into the next year. So we do try and comply with this. For a period there, we were actually more successful in bringing a greater number into compliance, but it kind of hopped up after we had some changeovers in staff in that unit. And so it's, you know, I guess what I can say is we do our best as a ministry to try and be as transparent and move the process forward as quickly as possible. But there are so many, I guess, variables in this, like, you know, from the start of the process, a lot of times we have to go do an initial assessment. Sometimes that requires going back to the applicant and asking them to refine the request because it's just simply too large. And sometimes there are fees attached after which the applicant withdraws the request because of the amount of time it takes to even staff outside of our unit. So there's a considerable number of steps to completing an FOI, and I would just say it's something that as a ministry we do have on our visibility wall. We track it regularly. Having said that, over the last probably, this year, this calendar year, we've had a few situations that have made our compliance with which I've discussed with the commissioner, a little bit more challenging. We had the malware incident with eHealth, and then that was quickly followed by the COVID. I'm not making excuses, but they did factor into our ability in recent months to address the regulated timeframes. But it's something that I do take seriously, and I have talked to the commissioner about.
Thank you. Just in note of the time delays, while the minister and officials are conferring, I wonder if the minister doesn't know the answer, if we can move forward with additional questions while officials are looking for them. You know, I know there's physical constraints with our setup today, and we're trying to scrutinize over $5 billion worth of spending. So I think I would appreciate that if we could do that. Thank you. In terms of access to information, just as a follow-up, have you given any thought to putting more of this information online? I know some other jurisdictions have done that. Where
possible, and I think we have made significant improvements over the years in terms of publishing pages on our website, but where we identify common theme areas where we're receiving multiple requests, and it's kind of a routine thing rather than having people FOI. We can put it on our website. In some cases, we get FOIs where it's actually already on our website and people just haven't, or have not looked or haven't found it. And so, yes. Thank you. I've got a few concerns that are specifically related to the COVID outbreak. With regards to the northern outbreaks, we've since heard some concerns that have been coming forward quite publicly in the media about access to medical appointments in more southern Saskatchewan locations, and those being limited by folks who are coming from outbreak areas. Can you speak to what has been done to communicate with medical providers about
the policies of travel surrounding the north.
Are you, you're asking as far as when the travel blockades were up, allowing to travel, or you're asking in regards to medical providers not providing care?
Access to medical providers, yes.
Okay.
So as you know, under the orders, residents of the north were allowed to travel south for medical appointments. I think what you're referring to is that there have been some providers that were not willing to see them just based on the situation up in the north. And a couple of weeks ago, and we're just pulling it out, but a couple of weeks ago we sent a letter to the regulatory bodies advising them that they should continue to obviously screen and do that sort of thing, but they should continue to see patients from that area.
Thank you. In terms of the northern outbreak situation, what did that teach us about our response to future outbreaks? Is there any lessons learned, things that would be done the same or differently as a result moving forward?
So I think that in terms of what could have gone better, and it's not just, I think, confined to the north, was that unfortunately the introduction of that virus into that community was from another province. Had there been, I guess, better communication between, or identification, I think, by our adjoining jurisdiction to the issues there, notification, we might have been able to get ahead of that. Subsequently, the lines of communication got much better, and we were made aware of work camp outbreaks in other provinces and such. In terms of the response to it, I think that, it's actually, considering the remoteness of La Loche and some of the unique challenges in the community, it's a lot went well there. We were able to mobilize quickly and establish testing sites in the communities. We had mobile testing gradually as the disease spread in the community, and we realized that strategy needed improvement. We actually started going house to house testing for COVID-19. We established isolation quarters for people that needed to be isolated separate from their households so that they didn't infect their entire household. And so we had some facilities up there for that. And then the other thing too, we were able to establish a managed alcohol program up there to assist residents who were isolating, so they were able to manage their addictions effectively, which helped to improve the success of isolation. And so, I think that Saskatchewan has been even acknowledged in federal circles for the response here. The SHA has, unfortunately. About a week ago, I was talking with some of my federal and provincial colleagues about this, and the numbers have come down so significantly in La Loche, and I think it was a real credit to that community and to the leadership up there and to the SHA staff. And then we've seen a resurgence because of a public gathering, and so it just highlights how sensitive, those large uncontrolled gatherings can be. And so we, unfortunately they're kind of back a little bit, but I think it was actually considering a number of factors and just moving people up there. I'm just going to mention something. The SHA put out a call to employees throughout the province, asking for people to redeploy there, and a number of people did. They volunteered to go up there, leave their families and that sort of thing, and live apart in a community that was experiencing some challenges and pose some risks. And so I think it was a credit to the SHA employees and the community for their response.
Thank you. In terms of a second wave, there have been, I don't know if we'll see a distinct second wave, and I don't know if anyone here knows that either, but what planning is happening for a possible second wave that could come in the fall, as many are predicting, and have any of the plans been altered to account for that?
So over the next few weeks, we had kind of, and the SHA had done the same, we had established or just stood up our Health Emergency Operations Center There was a provincial emergency operations center, and then the SHA maintained one. And, this was kind of something that was meeting daily to respond to the immediate needs and on weekends around COVID-19 through March and April and May. And so over the next few weeks, both the SHA and the ministry are transitioning to a bit of a different type of structure. In the ministry, we're calling it our COVID response unit. We're establishing an independent unit that will be very focused on several elements of our COVID planning going forward. And the SHA has established an incident command center as well that will continue to work on this. And there are several factors, I think, that, you said the when and if. I mentioned earlier that, we'll continue to monitor the modeling, the dynamic modeling, and Dr. Shahab will continue to monitor the epidemiology of this as we go forward. So if at any point, I guess, we see, a severe uptick or whatever, we'll be able to detect that, hopefully be able to contain it into a specific area if that's possible. If not, then other measures would be taking place. But, I think we're planning for the worst and hoping for the best. And so obviously our strategy includes looking at our surge capacity and continuing to make sure that we have all of the equipment and structures in place to manage whatever comes our way. So making sure we have an adequate number of beds, hospital or ventilators, an adequate number of protective or an adequate amount of personal protective equipment, making sure that, we can meet the mental health and social needs of our population, the medical needs as we go through another pandemic, potentially or wave 2. And so there are several things that these units will really, that will be their daily work, is to focus on and be ready if there is a resurgence in the fall. We hope not, but we're planning for it.
Are there any specific thresholds that have been put in place, say, with the rate of transmission, that would signal a planned backtrack of the reopening phases?
Points there. I think the intent is not so much if we do have some higher rates of positives in a specific area, it wouldn't necessarily be a case of sort of scaling back the Reopen Saskatchewan plan that you're asking about. It would be more a case of putting restrictions as necessary to that specific area, to that geographic area, if you would. The other day, I know Dr. Shahab had, I think, talked about it. I think it was one of the news conferences, and he was talking about sort of the things that would have to be looked at and considered. And a lot of it, involves containment. It's a case of where is it community transmission? Is it to a specific facility? What can be done to ensure that it's contained? He talked about a number of things there, making sure the health system has enough capacity, that preventative measures are established if it's in a workplace or a facility. It would really come down to what's the cause of the outbreak? Can it be traced? Can it be contained? And what restrictions would be necessary in that specific facility or that specific community to ensure that it doesn't get out of control?
It now being 5:30, we will recess till 6:30. It should be noted, though, the 16-minute late start that we had will be added to tonight's time. Okay, thank you, everyone. 6:30 sharp. Mohammed?